Welcome to our third lecture of our first class on medical device design and innovation. What we'll do for the next few minutes is take a closer look at this idea of the needs analysis related to biodesign. It is a centerpiece, it's a highlight of our course, and so we'll revisit this several different times. The outcome of a needs analysis is a clinical need document, and this really has four basic parts. First and foremost, of course, we need to know a little bit about the disease state fundamentals and to be able to characterize them. So we need to understand the state of the art of our understanding of the disease, knowing, of course, that changes over time. Next, we need to look at existing treatments. And of course, existing treatments can vary by institution, but there are some protocols, standard protocols for a lot of the standard disease states. And so it's just a matter of establishing through interviews or textbooks or research what the existing treatments are. In addition, we want to take a look at the stakeholder evaluation. Often people think of the beneficiary of a medical device as the patient. Well, yeah, that's true. The patient is a stakeholder in the process, but also the physician, the surgeon are stakeholders, as is procurement, as is the insurance company. There's a lot of stakeholders involved in understanding what is a clinical need. These all weigh in on whether or not the particular solution or the go-to-market strategy is going to succeed. You have to pay attention to the stakeholders in order to have a successful outcome. Then, of course, there's a market analysis. Just because we can identify a need doesn't mean the market's ready for it. There may be some very good reasons why the market cannot embrace this technology. For instance, in a medical device, maybe there's a supporting infrastructure that's not there. Maybe there's not complementary assets or complementary resources that are necessary for the device to be successful. Maybe there's not a backup plan. So there's a lot of different reasons why the market may not be ready for it, even if it's just return on investment or risk or the context of sales. So the clinical need document is decomposed again into four parts: understanding the disease state fundamentals, looking at existing treatments, performing a stakeholder evaluation, and a market analysis. I don't think there's anything too mystical about this or strange. This probably has application in many, many different disciplines. So even if you're not interested in biodesign, which I hope you are, the idea is that the talent in assessing these four components and integrating them into a clinical need document is a pretty useful skill to have. I think you'd agree. This is an interesting chart. This is something that has been tossed around for quite a while, and this is my adaptation of a number of different resources, so it's not entirely my origin here. But I think what we want to look at is and start to think about the idea of health management, which means this is really a low-risk intervention. This is wellness plans and things like that. Then there's this idea of demand management, and kind of the way to understand this and put it in the right context is to toss in the idea that demand management is associated with symptoms. So once somebody exhibits symptoms, now in the U.S. Sort of reimbursement follows only when symptoms have been established. So demand management is associated with the first occurrence of symptoms, and disease management is associated with the fact that the disease is ongoing and this is something chronic. So what you start to see, of course, is three levels of action. On the health management, this would be dominated by preventive services. Demand management, we'd probably look at more preventative programs. Of course, up here we have smoking cessation. This could be early testing, detection, surveillance. We can think of a lot of biosensors and things, wearables that could be used to detect and alert us to certain onset of symptoms that would result in preventative programs. And of course, case management is this long-term association with disease conditions that have been around for a while. The important thing is that in generally speaking, the low-cost, low-risk intervention is associated with preventative services, yet our structure and our reimbursement is only set up to provide assistance to the patient, reimbursement and assistance to the patient once symptoms arise. So in other words, if we're talking about diabetes, this span right here could be 20 years. And so what we really talk about when we talk about some of these chronic conditions is these are 20-year diseases, and by the time they appear, at the clinician's doorstep, they're expensive to take care of. So the assumption most often made in a lot of biodesign is that what we're going to do is focus on post-symptom reimbursable devices. And in our previous segment, we talked about context. So what I'd like to suggest here is that a more contemporary view of biodesign would be that the assumption isn't that it's not necessarily a post-symptom world we're living in biodesign, that in fact we could be actually looking on the sort of low-risk side, which involves preventative services. The BioDesign book has a great, just a wonderful diagram about market segments, and I really like this because it's a very visual and it's very impactful. And what happens is that the need is central to the process, and we've talked about this several times, but let's look at it differently. A lot of people will say, "Oh, we've got $1 billion market, blah 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 blah." But the market size is going to be mitigated by the market dynamics, and of course, market needs. So what we're starting to see, of course, is that the funnel, if you will, the number of players, the number of people, the number of candidates in a specific market are going to be channeled significantly so. And so essentially the idea is that in the market needs, we need to look at the extent to which needs are being met by existing treatments. They may actually be quite adequate, and our particular innovation or device or what we're trying to promote may not be well accepted. So we have to understand what the unmet needs and the market gaps are in order to see if there's a little room at the table for us to bring our device to see if we can solve a market need. Then, again, we've talked about this several times already. Need, and as I said at the very, very first lecture of this class, we're going to come back to this word need. Sometimes people get kind of sick of it, but really have to emphasize on that, because only after you've established the appropriate size of the market need, then can you go on to the willingness of pay. And interestingly enough, there's a bit of a challenge for many engineers in which, just because the technology works doesn't mean somebody will accept it. So we have to take a look at things like the openness of stakeholders to new inventions. Now remember, we talked about stakeholders being not just the end, the beneficiary of the device, but it could be the surgeon, it could be procurement, it could be the insurance company. So basically, I would encourage you to open up the BioDesign book, take a look at this figure, and I think, and of course, do the associated reading, and I think you'll start to see that this funnel really is quite useful to think about, and in terms of differentiating between what the market size is and what the target market is for your device as you do a market analysis. So let's touch base on one of our building blocks of the clinical need analysis and talk about disease state fundamentals. And the textbook outlines this in a nice fashion. In some ways you have to know the questions to ask, and this doesn't mean you have to be an expert in anatomy and physiology or pathophysiology, but it does help to know what are the key questions to ask. So let's just take a look at this particular. Of course, this is a carotid artery. Of course, I recognize that, and but what we're talking about up here is a problem in which we have, we need to do for a heart procedure. We have a coronary artery bypass graft. Of course, this is blockage around the heart. And again, I'm acutely aware this is the carotid artery, and that kind of thing. But the point is, let's suppose the problem is a blockage of the heart, and we're going to do this coronary artery bypass grafting. And this is very invasive and very expensive. And so this concept, somebody came up with a solution of this balloon angioplasty. And basically, as illustrated here, well, sort of illustrated here anyway, is that you use a catheter and you use a balloon to expand, and maybe you push the plaque to the side and open it up, and then sort of open up the artery, and so to restore the flow, you have this reperfusion of the area. And so, so this worked. The balloon angioplasty, it was a solution, and what happened was, it was moderately minimally invasive, and it opened up the artery, and this allowed blood to flow and health to be restored to some extent. But the problem therefore that followed from that was recoil. That is to say, over a period of time, the patency of the artery was mitigated and compromised, and so then we started to have a closure and occlusion again of the artery. Well, then the solution there is, well, okay, when we put the balloon in, let's just add a bare metal stent. And so here's an example of a bare metal stent, as I showed you earlier. What that is that the bare metal stent would actually hold the plaque to the side, for instance, and then, of course, we'd restore the flow that way. Well, okay, that worked well, but the problem there was restenosis. And of course, stenosis is the occlusion, and so it's the recurrence of the blockage, and this is very common for people with coronary stents. And so I say, well, okay, maybe it's the bare metal, and so okay, so now what we're going to have is a drug-eluting stent that avoids the restenosis, but then after a period of time, there's late stent thrombosis. So when we talk about the disease state fundamentals, and pardon me if I didn't get all the details right, but the point is, when we talk about disease state fundamentals, what we're really talking about is being able to work ourselves through what some of the current anatomy and physiology is, what the pathophysiology is, and actually, what solutions are there, which solutions have been tried, and the consequences and the series of problems and solutions. So simply by walking through this series of problem, solution, and trying to characterize it in terms of the disease state fundamentals, you gain a real sense of the condition and start to begin to think about why, which, of course, whys are great catalysts for helping us be creative and asking questions and questioning the status quo. So when we think of this, moving on to the existing treatment, so we've looked at the disease state fundamentals, and now that was that first building block, and the next building block is this idea of the existing treatment. So it's very useful to draw up these trees, and the textbook has several of these that are extraordinarily illustrative. So basically what you do is you say, okay, look, I know the location of the blockage, and I know the amount of time that the blood flows, and so sometimes we have damage due to reperfusion, and so what we have to do is we have to understand whether the patient can tolerate the treatment, because there might be some reperfusion damage, and so they're not eligible. So in other words, you have this acute myocardial infarction, and when you do your EKGs, what you try to do is, if candidates for this catheterization, they have to have this elevated ST segment, and this is what would qualify them for the operation at a very high level. And so then you work your way down, and you say, okay, so the person's eligible, and then eligible for reperfusion or not. This could be due to age, condition. There could be a variety of comorbidities that would prevent the procedure from being done, because again, the reperfusion would be damaging to them, and we could talk a little bit about that later. But basically, if you're eligible for the reperfusion procedure, then the question is, could you be catheterized or could you not? So what we're starting to see is that when we think of the disease state and the whys and the solutions, this could be basically the root of this could be the heart attack, and then of course what we have to do is look at all the different pathways that we can go and understand that the catheterization is just going to be but a fraction of all of the possible conditions, the points we could end up on this chart. And of course, we could either take that even further to looking at low ejection fraction, high ejection fraction, and many times you actually have to have a high enough ejection fraction to have a healthy heart for the procedures. But let's take another look at this, and let's add some numbers, and I think it'll be a little bit more informative and illustrative of the point we're trying to make here. And that is to say, let's add in some data. Okay, so let's just say that in the United States, there's 865,000 new and recurring cases of MI. And, and so, out of that, we do some more studies, and we discover that in field there's a mortality rate of 14%, so there's a survival rate of 744,000, and you can follow this picture and see that 42% match this ST segment, the elevated ST segment, which makes them go down this path, this particular path, and they might be or might not be eligible for reperfusion. Studies have shown, and numbers show, that like 70% of the people are actually eligible, and it's actually a much smaller fraction that's not eligible. And if we go down further and say that those that can be catheterized versus can't, again, the case where we can't catheterize the person is smaller, and so really it's 89%. So the key message here is that once we've developed this tree, this diagnostic tree, some people say, oh, well, this is a big market because there's 865,000. Really, when we look at the addressable market for the people with a specific disease state, then we actually see that it's actually much smaller. So to create this kind of chart is to really build credibility in your analysis, because it shows you understand what the addressable market is, not just hung up on what the overall market is, which of course is misleading. And of course, another view of this is take a look at strokes, and here's a case where we one of the challenges with strokes is the ability to swallow properly, this dysphagia management issue that occurs. And so once again, you can see that a chart like this can be fairly informative. If we have so let's just say roughly we have 750,000 strokes a year, and about 225,000 experience dysphagia. And then what we do is keep walking down the tree here. We want to create these trees, and there's a specific point I want to make here. So let's just jot right down here and say that usually when you have dysphagia management, if you overlook, though it's hard to do that, if we look beyond aspiration death, we see that about 200,000 people who have dysphagia as a result of stroke actually have a PEG tube. And now what's really interesting is that a small fraction of those have a trach and a PEG tube. So in this case, you have a very, very small number. So let's just say, 32,000 versus 750,000. Obviously, this is a much, much smaller addressable market. One thing to think about, though, in this case, if we think of meeting a need for somebody with a PEG tube and a trach tube, and we realize that if we can solve this problem for the person, that is to say dysphagia management, then as we improve our ability to stimulate the nerves in such a fashion that we don't actually need the trach tube, then what we really do is we work backwards. Okay, this is what I'm trying to get to. We may have a situation in which the market size is limited by the PEG trach tube market, but in fact, if we don't have the issue of the trach tube and we have a clever way over time to assure the airway is clear, then the market gets bigger because we're really looking at a PEG tube market. Okay, so that's the point in this slide. Not only is it that the market analysis and understanding the disease states and the treatments, not only is it that we can identify of all the strokes which are addressable by our technology, but indeed, if our technology evolves over time and we have a second and third generation, it may just be that our addressable market is bigger. So if you think about it, a person with a PEG tube and a trach tube is also a less risky person in some ways because there's so much attention being paid to their health care. So what we would want to do is sort of work out all the issues at this level, knowing that once we get up to this level of a PEG tube patient, that indeed we would want to have a robust system, and that robust system has been addressed by looking at our initially very small market of, again, PEG tube, trach tube patients of all of those that have had strokes. So let's now move on to the third block, which is a stakeholder analysis, and this is something I've talked too quickly, so we can kind of run through this. You have to think to yourself, who's going to use this? Who's going to buy it? Who's the customer? Is it the patient? Well, increasingly high deductibles, people might suggest, yeah, the patient is paying for it. Who's the user? Is it a physician or is it a surgeon? What's the referral chain? Who actually is paying for this? And what outcomes will the stakeholder need to see? That is to say, what is the value we create in the mind of the patient? All these things need to be worked through because this represents a complete view of the stakeholder, not just necessarily the isolated view of the patient or the physician. When we think of something like who will buy, we think of the complexity of the delivery system. We've got, you might be thinking, well, I'm just going to invent something and we're going to manufacture it and sell it. Well, I think it's pretty easy to see that, for instance, in home medical equipment, we have to go through a dealer network, we might have to go through distributors, there might be a group purchasing. You begin to realize that to reach the customer sometimes might be a little harder than you think. Maybe we have to go up through here, go through CMS, understand what the payer rules are for durable medical equipment. There might be some eligibility conflicts. The physician delivers to the patient. Eventually, the patient gets served here. But is your customer the dealer network? Is that who the customer is? Or is the dealer network, or is the customer actually the patient? So these kinds of diagrams represent the infrastructure of the delivery to the marketplace that you as a designer need to be aware of. Many engineers don't like to think about this because actually it's hard to understand what the system is and even harder to quantify it, which of course is why a lot of people will avoid this kind of diagram. But it is essential that we do a diagram, that we perform a diagram like this to really understand the difference between the end user, the customer, and the pathways of reaching both the customer and the end user.